Hello, everyone. Welcome to our podcast where we bring the connection between the lab and the clinic together to discuss how the latest generation of testing can help identify pathogens, to get a diagnosis, and harnessing potential partnerships between lab professionals and infectious disease providers. In early 2003, just to set this podcast up, a rare and deadly form of a fungal meningitis began appearing in the United States, primarily among patients who had undergone cosmetic surgery in Matamoros, Mexico. Over this past summer, I sat in a really great lecture from our guest today, Dr. Sarah Bergbower, and I was at the ASCLS Lab Jam, and I heard this topic that she talked about. So she joins us today from Illinois Eastern Community College, Olney Central College, and it's my pleasure to welcome you, Sarah, to the show. You're our second guest, and I really look forward to hearing from you today. Maybe to start out, could you provide a bit of an overview of the situation and the role you played in it?
Sure. Well, first of all, thank you so much for having me on this podcast. It's really quite an honor, especially to be following up Dr. Lapizzato, who was the first. I've always been a fan of his lectures and any of his talks I'm trying to attend, so I'm pretty excited. So an overview of what happened. It was 2023, as you mentioned, and I was still a DCLS grad student. I was rounding with the infectious disease service. And just to kind of set up for what these services look like, they are usually teams that involve an attending doctor, fellows, residents, med students. There might be a pharmacy student, and then there might be a DCLS student, and that was me. Now, I love microbiology, and I was pumped about doing a rotation with ID, especially for my last rotation. So on my first day, I met my attending, and he goes, "Oh, DCLS, lab, nice. Welcome to the team. So maybe you can solve this case." This case paints a picture of meningitis. It has a history of cosmetic surgery tourism. I'm naive, I'm ready to go. And so I start pulling up the EMR, I'm looking at the labs, and they are all over the place. There's contradicting information that I'm finding. I'm getting concerned. So they had been managing this patient for about a month. The prognosis was not good. And over the course of that month, there were no organisms that were able to be confirmed. Nothing grew from any cultures, from any kind of source. And when they did a CSF panel early on, it gave false positives for both a virus, which was HHV6, and a bacterium, which was Haemophilus influenza. And instead, they were leaning towards a fungus because they also had a positive Fungitel assay, which, to be honest, I had never even heard of that as a generalist medical lab scientist with experience in a rural hospital background. So, all right, a fungus. Even though they also had one other test that was kind of setting all this up. It was really cool. They did a cell-free DNA sequencing. And this didn't have anything detected in it at all. They were also suspicious of a fungus, though, because they thought that it was connected to another case that was located at another institution. And this other case had similar manifestations, had the same surgical history. And in that particular case, they did isolate Fusarium. As it turns out, these cases were all part of an outbreak, and it was unfolding in front of our eyes. It was quite the experience.
Yeah, I bet. I actually can remember kind of that whole scenario because I remember the CDC actually issued a notice to my memory, kind of to alert doctors and place Matamoros on a level 2 travel advisory. And so, for those of you out here who may not know what that means, it basically means the CDC will occasionally release these types of advisories, and it's really to kind of urge a certain sector of the population that might be traveling to these areas that this suspected outbreak's going on. And for this one, they were basically targeting anyone who had received an epidural anesthesia at the clinics between a certain date. I believe it was early January and in May. So, just trying to warn people. So when you were kind of, that's fascinating. Again, talking about the lab piece of that and kind of thinking about your role in it. How did you interact with the infectious disease provider in terms of kind of adding your diagnosis to the problem?
So while I did do my best to make sense of the lab results and provide possible diagnostic explanations, I do want to make it clear that I did not have an influential part in actually making the diagnosis.
Right.
Instead, I shifted my focus into what I perceived as a necessity to reestablish trust in the laboratory. Because as a laboratorian, I kind of felt disappointed in the false positives and false negatives that were
Right.
generated. So remembering that no lab test is 100% and recalling the concepts of sensitivity and specificity and positive and negative predictive values, all the different types of errors that go into those calculations throughout the entire total testing process. So we're talking all the way from like pre analytical errors to post and everywhere in between.
Right.
I kind of made it my own personal mission to explain where these unexpected results may have come from, because I was concerned that future patient diagnostics might depend on the situation if providers were to lose trust in the laboratory. And for my own sake, too, I wanted to know why. So your question is, what did I actually do as a DCLS on the case especially when it was so far progressed? So I investigated causes of the false positives on the meningitis panels. I looked into literature that reported on similar occurrences. I correlated the other laboratory testing results with the negative cultures. So I tried to identify gaps, suggest further testing in efforts of making an organism diagnosis. So this included things like making sure that we had actually excluded everything, even what I call, the zebras, the really odd possibilities. I looked for possible interactions in the Fungal assay because I, for one, wasn't convinced which results to believe. And I also called the medical director of the cell-free DNA next generation sequencing company to figure out why such a really cool method, in my opinion, would fail to detect any organisms. So all of this information I collected, I reported back to the team, and it was certainly an educational experience for everyone.
Yeah, I can only imagine. Again, it really gets to the heart of this podcast and kind of talking about the role of the laboratory and whether it's at the level of a medical laboratory scientist or a technician, or certainly at the level of a DCLS. And again, just to remind our audience, the DCLS and Dr. Bergbower will talk about this probably in her closing. They're really at the intersection of the clinician and the laboratory, and their role is to do exactly what she just said. And I know I'm preaching to the choir out there, but many times people don't realize that our background is nothing but troubleshooting in the laboratory. And often a physician or others may just not have that background or the time, in all honesty, to kind of dig in and do that research. It sounds like you were able to dive in there and get some of that done. What were some of the challenges for you guys in kind of coming up with a final diagnosis, and what really helped you ultimately get to fungal meningitis in this case?
Through steps of outbreak investigation in collaboration with the CDC, as you mentioned, and even other institutions that were having these cases, our patient's case was identified as a probable case given the history and the symptoms. And the problem, though, with this was that we couldn't actually prove that Fusarium was implicated. We had a hunch, but couldn't actually prove it. We had a lot of parameters that were definitely suggestive of this, especially like the CSF parameters. So we had the appearance, the opening pressure, the white count, protein, glucose, all of these. Okay, again, they were suggestive, but they weren't conclusive
Right.
of fungal meningitis at all, let alone Fusarium. The Fungal assay, that was a really strong indication of fungal meningitis. It detects the presence of a fungal cell wall component, which is 1,3-beta-D-glucan. It has really good sensitivity and specificity for most of the organisms that it has been tested against in the literature. We also had the cell-free DNA next generation sequencing, but as I mentioned, that failed to return positive results. And that's because the validated sample type was blood, not CSF. And because our case and all of these cases were cases of iatrogenic meningitis, where the infectious agent was injected into the CSF directly, the organism didn't cross the blood-brain barrier to go to the CSF from blood. So it wasn't until after the patient had actually passed that the sequencing company did discover the presence of Fusarium, but it was under the limit of detection. And again, it was some time after the patient had passed, but a culture did finally isolate Fusarium. So the challenge in this case, and this is just my opinion, it wasn't so much the struggle for an identification, so much that it was finding appropriate treatment. Because Fusarium doesn't manifest itself like your more common fungal species, and it's not treated the same way either. When we have reports of Fusarium meningitis in the literature, it's usually in the immunocompromised, not the immunocompetent. And at that, they're still rare to find those. So predicting and understanding what was going on and what it was doing in vivo, this was difficult, not to mention severe. Many of the patients in the outbreak experienced hemorrhage and strokes, and the fatality rate was higher than that of a previous recent outbreak that was linked to C-sections. And the strain in this outbreak isolated, the strain that was isolated in this outbreak displayed resistance to the standard voriconazole therapy. So that made it even more difficult, of course. So all of these factors together, I think, made management extremely difficult.
Yeah, wow. I mean, it always takes me back to some of my early work in doing different viral and different fungal types of assays, even at the public health level, because it's really fascinating to listen to you talk about that. But it's also we always have to remember that it's connected to a patient in a very unfortunate situation, right? You go in, probably seeking some type of procedure. You think it's not a big deal. And for the audience, again, Fusarium is kind of a typical environmental fungal agent and probably wouldn't be looking for it in a normal type of situation. And so fortunately, you had those assays and you had that kind of determination to dive in and kind of think about that. With respect to kind of the overall case, you kind of talked about some of your challenges. I'm kind of curious if there's any other particular points that you might find is really important for some of our listeners, whether it's from a microbiological standpoint and how your expertise as a laboratorian, as a DCLS, really helped drive this information on the side of the false positives and some of the other false negatives and some of the other things going on.
So I think some things to remember is just everything that we've been taught as medical laboratory professionals. Because like I said, at first I was kind of disappointed in these results because, providers, especially I feel like are really, heavily weighting their next diagnostic decision. Maybe it's a decision for therapy on laboratory results. There's a statistic that 70% of these decisions are based on laboratory results. So it's important to remember, and I think as laboratorians, it's maybe a little bit easier because we're, seeing these every day, but we got to remember where these results are coming from, what's actually taking place within the methodology. What is the instrumentation detecting? What types of interferences might get in the way of this? Where does this number just come from?
Right.
Because that, as you mentioned, is what is going to ultimately lead to your troubleshooting ability to figure out, okay, is this number that I'm getting, trustworthy? Does it look correct? Does it make sense within the context of the patient case?
Yeah, it absolutely, as an educator now at an MLS program, it just really gives me ammunition too to go back in and use these types of cases to share this podcast with my current students and my alumni to really, sometimes inspire them and to let them know that in the day-to-day difficulty of obtaining this major, certainly the DCLS is one that's even higher level, doctoral level work, how critically important what they do is to the overall patient outcome, right? I mean, I think most people we know don't see that. We're kind of behind the scenes. But inevitably, when we think about, I mean, I remember this during the pandemic, right? Talking to our fellow colleagues or to people consuming healthcare in a different way, I think most people think that when you get a result from a lab test, it's good to go, right? And that it should happen quickly. You should be able to create a new test overnight, whether it's a novel SARS virus or a fungal outbreak. And it just doesn't work that way. It takes time. It takes many years to train our professionals, and you cannot create a medical laboratory professional overnight any more than you can create a physician or a nurse or anyone else. So it's really wonderful to have this opportunity to kind of talk with you. And kind of as we kind of finish up this topic a little bit today, so really, congratulations on obtaining your DCLS. It's a wonderful newer terminal degree in our profession, and I'm certainly steering many of my alumni to consider it. Do you think your education in this particular area, being a DCLS, helped you and kind of maybe walk through some of that part that the audience can get a little bit more insight into what a DCLS does on any given day?
Sure. So I definitely didn't save the day because of my DCLS. And I have to say that the attending infectious disease specialist and the fellow that was on the case, they both did a wonderful job at providing
Absolutely.
management. They both had fantastic bedside manner, and they both had genuine care. And this was an educational case for me. But I feel that the benefit of my DCLS, though, was that it gave me clinician speak. I could understand the actions and the rationale of the providers. I could also express laboratory concerns with them effectively. And being able to round with the providers face to face, I think also helps establish relationships of mutual respect and trust. I would recommend any hospital to place a laboratorian on rounds with providers, DCLers or not, for this very benefit. I strongly advocate for interprofessional diagnostic management teams for a more holistic approach to healthcare.